Hello everyone, my name is Mohammed Sheem and I'm a member of the Healthcare Committee of the European Parliament. First of all, thanks for having me. Unfortunately, I'm not able to be present today, but I would still like to say a few words. I believe the right on receiving appropriate healthcare is a fundamental right. And for a lot of well-known diseases and illnesses, this is already the case. But for more complex and rare diseases, this is often not true, simply because we don't know enough about the disease. The same goes for the chronic fatigue syndrome. Not only is there no scientific certainty about the cause of chronic fatigue syndrome, there's also no proven effective cure. Meanwhile, it is estimated that between 2 and 3 million people in Europe suffer from chronic fatigue syndrome, which shows the magnitude of the problem. Whether we want to prevent chronic fatigue syndrome in the future or find possible cures or effective treatments, additional research is absolutely necessary. That's why I always fight for strengthening research and innovation funds in the European Parliament and the development of a strong European health union. We need the means to fund research for rare and complex diseases to improve the lives of literally millions of people. And that's why the work and efforts of organizations like the European EMEA Alliance is also very important. I sincerely hope that the research will soon lead to scientific breakthroughs in combating and treating the chronic fatigue syndrome so millions of Europeans can get the care everyone deserves and we can improve the quality of life for all. Thank you.
Good afternoon, everybody, and welcome to today's roundtable to discuss ME/CFS in Europe. Obviously, before we begin, I'd like to thank MEP Mohammed Sheem for his opening remarks. He's done my job for me in terms of setting the scene, in terms of why we're here today and what we're going to be discussing over the next number of hours. Now, it is going to be quite a lengthy meeting, particularly for an online meeting, so please do bear with us. We have a packed agenda full of experts bringing different stakeholder perspectives to the meeting today. And our aim is not only to discuss the issues, the challenges and the barriers that we find in the ME community, but to really start thinking about potential solutions, not just from the scientific and research perspective, but also from a policy angle. What policy hooks can we really optimize to drive forward the public health and research agenda for those living with ME/CFS in Europe? I'm Donna Walsh and I'm the Executive Director of EFNA, the European Federation of Neurological Associations. For those of you who are unfamiliar with EFNA, we're an umbrella of pan-European disease-specific neurology patient groups. So we include members such as the European Multiple Sclerosis Platform, the Stroke Alliance for Europe, the International Bureau for Epilepsy, the European Parkinson's Disease Association, and so on. We currently have 20 members, and that of course includes the European EMEA Alliance, with whom we're really pleased to co-host today's meeting. Just a few housekeeping rules before we get to the content, which I know is what you're all here for. But to the presenters, I would just like to remind you that everybody's been given a 10-minute slot, and we really do need to stick to time. So if anybody is running close to 10 minutes, I will send you a message in the chat. Do look out for that. And if we run over 10 minutes, I'm afraid I'm going to have to play the bad cop on this occasion and interject so we can give everybody the opportunity to make their presentations here today. For the participants, I would encourage you to use the Q&A function, which you'll find at the bottom of your screen. And there you can ask not only questions, but also make comments, provide feedback as we go through the presentations, because we want to hear your thoughts and your perspectives. But as it's a big group of over 100 people, we will try to use the Q&A as much as possible, so we will limit interactions from the floor. We will take questions as we go through the presentations if some of them are immediate or you require a quick clarification. But in the main, we will try to keep the questions for the discussion at the end of today's session. So please do continue to ask your questions as we go. If we don't get to all the questions, and I'm trying to manage expectations up front, then we will follow up with people individually after today's meeting. And this is the first in what we hope will be a series of events and activities. So lots of your feedback can be taken up at another time if we don't get through everything here today. Now, for many years, ME, like many other neurological disorders before it, has been neglected and even contested in many quarters. But today we see that there is some renewed momentum behind diseases like ME, particularly, I think, because of the interaction we're now seeing between long COVID and some of these other diseases that are sometimes put in that post-viral fatigue or malaise bracket. And this could be the open door we need to really push ME onto the public health agenda. And we will get to all of these discussions as we move through the presentations today. But for now, I want us to really take the patient perspective and bring it to the center of the discussion, because we need to contextualize the dialogue that will follow in the realities of those living with ME across Europe and beyond. And to do this, we have a short video that we are going to share with you. This is quite a moving video, and I do hope that it won't cause upset to any of our participants here today, but just a disclaimer up front that this is quite a moving testimony that we're going to show. But I think it's important that we really show the realities of what it means to live with ME, which is such a severe, disabling and debilitating condition. So let's take a look at that video now.
Nobody can say that I didn't put up enough of a fight. For 16 years I have battled increasingly severe ME/CFS. My condition has steadily deteriorated and new additional medical problems have regularly appeared, making it ever more difficult to endure and make it through the day and night. Throughout this time, I have invested almost every bit of my tiny energy in the fight for treatment for us patients. Severely ill, I have advocated from my bedroom for research and establishment of biomedical clinics to get us proper health care. I have researched all possible treatment options, got in contact with international experts, and methodically tried out every medication, supplement, and regimen suggested. Sadly, for all the work done, we still don't have adequately sized specialized biomedical care for patients here in Stockholm, Sweden, or hardly anywhere on the planet. We still don't have inpatient hospital units adapted to the needs of the severely ill ME/CFS patients. Funding levels for biomedical research remain ridiculously low in all countries, and the erroneous psychosocial model which has caused me, and others, so much harm is still making headway. And sadly, for me personally, things have gone from bad to worse to unbearable. I am now mostly bedbound and constantly tortured by ME/CFS symptoms. Some of you have followed my struggle to find clothes and bed linen I can tolerate. Lately, I am simply running out. I no longer have clothes I can wear without my skin burning up and my body going into an allergic state. This means I no longer see a way out from this solitary ME/CFS prison and its constant torture. I can no longer even do damage control, and my body is at the end of its rope. Therefore, I have gone through a long and thorough process, involving several medical assessments to be able to choose a peaceful way out. I have received a preliminary green light for accompanied suicide through a clinic in Switzerland. When you read this, I am at rest, free from suffering at last. I have written this post to explain why I had to take this drastic step. Many ME/CFS patients have found it necessary to make the same decision. And I want to speak up for us, as I think my reasons may be similar to those of many others with the same sad destiny. These reasons can be summed up in 3 headers: unbearable suffering, no realistic way out of the suffering, and the lack of a safety net, meaning potential colossal increase in suffering when the next setback or medical incident occurs. I want to stress something important. As for most other ME/CFS patients who have chosen suicide, depression is not the cause of my choice. Though I have been suffering massively for many years, I am not depressed. I still have all my will and my motivation. I still laugh and see the funny side of things. I still enjoy doing whatever small activities I can manage. I am still hugely interested in the world around me, my loved ones, and all that goes on in their lives, the society, the world. During these 16 years, I have never felt any lack of motivation. There are so many things I want to do, I have a lot to live for. If I could only regain some functioning, quieten down the torture a bit and be able to tolerate clothes and a normal environment. I have such a long list of things I would love to do with my life. Many of us severely ill ME/CFS patients are hovering at the border of unbearable suffering. We are constantly plagued by intense symptoms. We endure high-impact, every-minute physical suffering 24 hours a day, year after year. It would be easier to handle if there were breaks, breathing spaces. But with severe ME/CFS, there is no minute during the day when one is comfortable. Every move of every day is a mountain climb. Every night is a challenge, since there is no easy sleep to rescue me from the torture. I always just have to try to get through the night, and then get through the next day. I am unable to listen to music, radio, podcasts or audiobooks, or to watch TV. Too ill to manage more than rare visits or phone calls from my family and friends. And sadly unable to live with someone. This solitary confinement aspect of ME/CFS is devastating. It is understandable that it has been described as the living death disease. A very important factor is the lack of realistic hope for relief in the future. It is possible for a person to bear a lot of suffering as long as it is time limited. But the combination of massive suffering and a lack of rational hope for remission or recovery is devastating. It is unimaginable to cope with a whole life with the body in that insufferable state every day, year after year. If we knew there were relief on the horizon, it would be possible to endure severe ME/CFS and all the additional medical problems, even for a long time, I think. Sadly, we haven't been granted this feeling. On top of this, it is very likely that in the future things will get even worse. I have no safety net at all. With severe ME/CFS, it is impossible to tolerate normal hospital care. The sensory overload problem and the extremely low energy levels mean that a normal hospital environment causes major deterioration. There is simply no end to how bad things can get with severe ME/CFS. I realize that when people hear about my decision to terminate my life, they will wonder about my coping skills. While it was extremely hard at the beginning to accept chronic illness, I have over the years developed a large degree of acceptance and pretty good coping skills. I have learned to cope with massive amounts of pain and suffering and still find bright spots. I would have been content even with relatively small improvements and a very limited life. But I am not able to cope with these high levels of constant physical suffering. This is not a rash decision. It has been processed for many years, in my head, in conversations with family and friends, in discussion with one of my doctors, and a few years ago in the long procedure of requesting accompanied suicide. For me, and I believe for many other ME/CFS patients, this end is obviously not what we wanted, but it was the best solution to an extremely difficult situation and preferable to even more suffering. It was not a hasty choice, but one that matured over a long period of time. This blog post has taken me many months to put together, but I felt it was important to write it and have it published to explain. and hopefully illuminate why so many patients consider or commit suicide. And most importantly, to elucidate that this circumstance can be changed. But that will take devoted, resolute, real action from all of those responsible for the state of care, research and dissemination of information about the disease. Sadly, this responsibility has been mishandled for decades. If you are a decision maker, here is what you urgently need to do. You need to bring funding for biomedical ME/CFS research up so it's on par with comparable diseases. As an example, in the US that would mean $188 million per year. You need to make sure there are dedicated hospital care units for inpatients in every city around the world. You need to establish specialist biomedical care available to all ME/CFS patients. It should be as natural as RA patients having access to a rheumatologist or cancer patients to an oncologist. You need to give ME/CFS patients a future. You need to give ME/CFS patients a future.
Oh, wow. What a powerful, moving video, I think, and a sobering reminder to us all of why we're here today and why meetings like this need to take place with all of the stakeholders around the table. As Anne said twice, and I'll say again, we need to give ME/CFS patients in Europe a future. And this is what we need to start to think about today, not just the barriers and the challenges and the issues, but the solutions. How are we going to get this done? And as she also said, we need devoted, resolute and real action. And hopefully this event will be the first step in that direction. Now, moving on to our next small video before we really get into the content today. And we have a message from the man of the moment, Dr. Tedros Ghebreyesus, who you will know is the Director General of the World Health Organization, has been leading the work in fighting the COVID-19 pandemic, but who has taken some time out of his busy schedule to record a short message for this video today. And for me, this really does signal that the door at WHO is open for ME/CFS, and we need to think about how we push that further open and really make our way onto that public health agenda. So let's take a listen to what Dr. Tedros has to say before we move on with the following presentations.
Distinguished guests, dear colleagues and friends, the natural history of COVID-19 and its associated long-term consequences are just being unraveled. In fact, post-viral malaise syndromes have a long history. They were reported as early as 1891 after influenza epidemics. As the COVID-19 pandemic continues, there is emerging evidence regarding the long-term consequences of many of those affected. These long-term effects appear to happen regardless of disease severity or hospitalization. In August of last year, I met with the representatives from the Long COVID SOS patient group and affirmed their call for recognition, research, and rehabilitation, as well as communication. WHO has established the codes for post-COVID-19 conditions in the international classifications of diseases. In the WHO guidance on clinical management of patients after acute illness, we emphasized the need for access to follow-up care in those who have persistent, new, or changing symptoms. Moving forward, we need to increase the attention to these conditions in national and global research agendas use artificial intelligence, precision medicine, and other novel technologies to consolidate fragmented research and identify new treatment options, including in low-resource settings. I wish you a productive conference, and I look forward to hearing your findings in this critical and evolving area of research. I thank you.
Okay, well, great to hear from Dr. Tedros. And although he didn't mention ME specifically, I think he did mention some of the priorities that WHO will be looking at as we move into the post-COVID recovery planning. And we need to think creatively about how we could use some of those hooks to bring ME into that mix. But I'm going to park that for a couple of minutes, and we will come back to this link between long COVID and ME discussion later in our meeting. But first, we're going to focus a little bit more closely on ME itself. And we're going to start to hear perspectives from the patients, the researchers, the clinicians, and the industry working in that space. But first, we're going to hear from the policymakers. And we are going to give the floor to Dr. Catherine Burns, who represents the European Commission's DG on research and innovation. And Catherine, I believe you're specifically working in the area of combating diseases. So we'd be really interested to hear your perspective in the next 10 minutes in terms of what the Commission is currently working on in this space, and perhaps how the ME community could maybe benefit with and align with some of your upcoming activities. I believe you'll share your own screen, Catherine, so the floor is yours.
Absolutely, Donna, and thank you very much for the introduction. And it's really a pleasure to be with you all this afternoon and to discuss with you a little bit what we are planning in the future concerning the research on brain. So let's go straight into the matter. And next slide, please. Thank you. So I will give you a little overview of what the European Commission has been doing in brain research in Horizon 2020, our framework program for research and innovation, and then introduce Horizon Europe, which has just been adopted and will fund research over the years until 2027. Next slide. So it's not a surprise to anybody that the global burden of brain disorders is really very, very high and is actually the first cause of disability adjusted life years and also the second leading cause of death after cardiovascular disease. And over the past years, we have also seen this burden very much increase, and notably when it comes to mental disorders and with the current COVID-19 pandemic and the associated anxiety and isolation due to the pandemic itself, and also due to the public health measure taken to contain the virus, it's probably going to get even worse. Next slide. So the European Union has been supporting brain research over the past years, and I should actually now probably say decades, to address this major European and global societal challenge. Via our research, we have tried to better understand brain health and disease. We have tried to develop personalized preventative approaches, diagnostics and treatment, and we have tried to support effective public health policies in that area. Research support, it spans the full research spectrum from basic translational clinical research to more public health oriented activities, including blue sky research with frontier research, as you can see there, and the support to training and mobility of researchers. Under Horizon 2020, we have now reached almost 5 billion euro dedicated to some 2,800 projects with participants from roughly 100 countries. And this is a really important increase compared with the previous framework program for research and innovation. A big part of brain research is actually dedicated to collaborative grants, as you can see, which allows cross-disciplinary approaches, bringing different types of expertise, cross-country research, and this is very much necessary to address multifactorial complex disorders of the brain. Next slide, please. We have also tried to support the structuring of the brain research area at European and global levels via a number of various initiatives and partnerships, public partnerships with our member states, such as the ones on neurodegenerative diseases or neuroscience, so-called ERANETs, which are coordinating national research activities, developing strategic research agendas, and issuing joint transnational calls. Also public-private partnerships like the Innovative Medicine Initiative, which is a partnership with the pharmaceutical industry to try and speed up the development of innovative medicines. And also sat with funders around the globe, for instance, in the Global Alliance for Chronic Disorders, which focuses on implementation research in low and middle countries, or in the traumatic brain injury area, where we perform comparative support, comparative effectiveness research in traumatic brain injury. So with these partners, we agree and align research agendas in order to achieve efficiency of scale and prioritize research with a view to accelerating delivery of concrete results and to avoid the waste of resources. I would like, next slide please, to focus a little bit more on one of our most recent projects, which is actually coordinated by the European Brain Council, and is about a European brain research area. So it is currently ongoing, and its strategic focus is to develop a shared research agenda, mapping the brain research landscape, identify priorities, actions and gaps in brain research, and develop a shared European brain research area. So it will accelerate exchanges between researchers in various research initiatives and explore also the possibilities for broader scale cooperation, also at global level, and identify areas of neuroscience where the need for enhanced coordination of research communities into active clusters are particularly acute. And this will serve as the basis, as an input for reflection for a future European partnership on brain health, which we will develop in the coming years. At least we will start reflecting with stakeholders and member states, and it is expected in the second part of Horizon Europe. And I'm pleased to see that the European Brain Council is present today, so probably Mr. Destrebeek will want to say a word on that particular one. Next slide, please. So what is the status regarding brain research and ME/CFS? Well, actually, we have realized that we haven't funded many projects in that area so far. I have highlighted a couple on this slide. So first, the Help for Me project, which has developed a promising probiotic food supplement designed to counter the biological mechanism responsible for irritable bowel disease, either alone or in combination with other conditions such as ME. And another project, the EuroMene project network, is actually supported via Horizon 2020 as a cost action. And it is developing an integrated network of researchers working on ME/CFS. And this could provide the nucleus for further research at European level. There are other projects that we are funding, which could be indirectly providing more insight into ME/CFS, for instance, in the area of fatigue or area of pain. But altogether, we recognize that the funding going to that area is rather scarce so far. Next slide, please. Next slide. So, sorry, can you go back to the previous one? So what, the next one? So what are we envisaging to address this situation? Well, actually, we would like to launch a study under Horizon Europe, a scoping study, with regard to those under-researched areas, such as ME, CFS. There are others like Lyme disease, for instance, or low back pain, which are under-researched, but nevertheless represent a rather important public health issue. So we would like to initiate this study to allow for the identification of those conditions. And this study would then serve as the basis for potential future call topics under Horizon Europe. So this could support the ME/CFS research community to be more competitive when applying for funding in the future under Horizon Europe. Next slide, please. We heard already a little bit, Dr. Tedros, regarding COVID-19. We have heavily supported research stemming from epidemiology, development of diagnostics, treatment, vaccines, etc. I would just like to highlight that in one of the calls, we have concentrated on innovative and rapid health-related approaches to respond to COVID-19. And one topic was about behavioral, social, and economic impacts of the outbreak response. There we have one project ongoing regarding mental health. So how the crisis has impacted mental health and what could be done in the future to better address these issues. We have an evaluation of a call ongoing right as we speak regarding research and innovation to combat the threat of coronavirus variants. And this call also includes the long COVID aspects. So via this call, we might also, depending on the projects which will be selected, which we will know over the coming weeks, we will get to know a little, we might get to know a little bit more regarding long COVID aspects such as pain and chronic fatigue. Next slide. So a couple of words regarding the future Horizon Europe program, which will be launched in the coming days. It has been adopted. It builds on past experiences, investment and networks, and it was very much co-designed with all stakeholders via open consultations and our European Research and Innovation Days. We have developed also in collaboration with the stakeholders a strategic plan for Horizon Europe, which gives the general orientations that will be followed to make sure that there is a link between the political priorities and the priorities identified during our consultations and the work program that will be issued. So to keep a little bit the compass there. Very important aspect of Horizon Europe is that it will be impact oriented. So we intend to really address the societal challenges and to come up with concrete solutions for citizens and the society. So I believe that what we heard from the patient previously very much resonates there. We would like our research to make a real difference via what we will be funding. And there will be plenty of opportunities for collaboration under this program, which has a budget of more than 95 billion euro altogether for the 7 years. Next slide, please. I will not enter into the details of the structure to save a little bit of time, just to highlight that under the global challenges and European industrial competitiveness, there is a dedicated cluster on health. Next slide, where you will find all related activities regarding health research. In this slide, you can see that we will still dedicate quite a substantial amount of our overall budget to those global challenges and European industrial competitiveness. Next slide. So this health cluster will have more than 8 billion euro as a funding, and it is structured around 6 destinations, one of which, the third one, as you can see, is about tackling diseases and reducing disease burden. So we will have a number of activities there to better understand, better prevent, better diagnose and better treat diseases, and also get better prepared when it comes to the infectious diseases threats. Next slide. So what to expect in the work program? As I said, the focus will be very much geared on impact. So the broader topics will be organized around the impact that we expect from the projects. So these topics will detail the outcomes very clearly, and then it will be up to applicants to present then a convincing plan in order to achieve the impact described in these topics. The evaluation criteria, as we know them, are maintained, and the structure of the proposals is a bit simplified to facilitate your work. The publication of the work programs is expected very soon now, so I would invite you to stay tuned in order to get the latest information. Next slide. On this slide, which I believe will be shared, I gathered a little bit of information regarding where and how you can get the latest information. RNI days are upcoming next week, so I would very much invite you to attend, and as well as the info day for our cluster, where you will get all the information related to our first call for proposals. Next slide, and I would like to finish by thanking you all for your attention.
Thank you very much, Dr. Burns. A quick question for you that's come in on the Q&A before we move on to the next speaker. And it's around how can patient organizations or people living with various diseases get involved in Horizon Europe? So maybe your quick thoughts on that one.
Well, I think that collaboration is of the essence, and I already mentioned that we very much would like our research to deliver concrete solutions to citizens and the society at large. So the participation of patients would be very much welcome at different stages in the research. Certainly when it comes to preparing research and advising on what would really make the difference for you. And I would encourage associations then to reach out to the networks which are already existing, or to flag their interest to participate in such research, so that together with researchers, you can really concentrate the research where it would make a difference for you. So, and there will be tools to facilitate putting in contact the potential partners for the projects.
Great. And there's a couple of questions that really, I suppose, are asking the same thing, and that is, do you foresee that there will be some dedicated funding for ME/CFS specifically, rather than maybe as an element of broader topics or themes?
I think that is a particularly relevant and important question. As we have seen in the past, that our way of opening calls very broad and not focusing on diseases in order to allow the cross-feeding of the various disciplines might possibly disadvantage the competition in that particular under-researched field. So we really believe that this study that we intend to support will provide us with insights as to how we could really address that, because we really recognize that there is a public health demand there and burden there, as we heard also from the testimony. So it is unlikely that we will have a dedicated topic in that area, but we would really reflect regarding how we could nevertheless increase your chances of getting funded, your competitiveness with regard to other maybe more served areas.
So I guess that underlines the importance of getting involved in that scope and call and that study that you will have to really position ME/CFS as a major unmet need. And also, as you say, you know, there will be bigger calls on topics like digital transformation of healthcare, gender, for example, and so on. And maybe we need to think creatively about how we position ME/CFS as a good exemplar in those areas.
Yeah, I think you will have different entry doors. So do not only scrutinize for that particular topic mentioning in the title ME/CFS, but have an open mind and try to insert yourself where it would serve you best. And I'm sincerely convinced that you will have many opportunities to do exactly that.
Great, thank you very much. And as you say, we will have Fred from the European Brain Council with us later on to talk more about the work that they are doing on this European brain research agenda, and maybe perhaps how ME/CFS could find a home within that work too. So we'll come back on this particular topic later on. But in the interest of time, I just want to thank you, Dr. Burns, for attending. We will certainly be back in touch. But I'm going to move on and bring in our next perspective to this discussion, and this is the patient perspective once more, but this time with a more European angle. And Kirsten, the floor is now yours.
Thank you very much. I'll try to share my screen. There. And share. And
yeah, perfect.
Right. Well, today I represent the European ME Alliance, but I'm also chair of the Swedish patient organization for ME patients. The alliance, now let's go on, represents patients in 17 European countries. Anna Ötergren was a fantastic, wonderful person who fought for ME patients until her last day. Not all patients are hit as extremely hard as she was, but almost everyone describes difficulties in dealing with the health system in their countries. So this is a typical story when seeking primary care. First visit, usually after an infection from which the person has not recovered. The patient may look healthy during the visit and is told, all tests are normal, you're healthy, go for a walk and take control over your life. Or you've obviously been very stressed lately, diagnose fatigue syndrome or maladaptive stress reaction. Or your symptoms cannot be medically explained. It's all about your patterns of thought or your way of life. Referral to psychiatrist. Next visit. When the patient has tried to work and exercise and is usually worse and more in despair. Met with a comment, have you really tried to activate yourself? Perhaps referral to a specialist in cardiology, neurology, gastroenterology, etc. And there might be minor findings, but not enough to explain the patient's multiple symptoms. And friends and family begin to doubt that the patient has a real illness. And later, the patient may have learned about ME/CFS from different media. Met with comments like, there is no such diagnosis as ME/CFS. I don't believe in this diagnosis. There is no objective evidence. This is a case of MUS, medically unexplained symptoms. Referral to psychiatry. Or there is no agreement about ME/CFS. I won't set that diagnosis. It will not be accepted by the health insurance agency anyway. I could write, for example, depression. Or you're not ill, you're maligning. Parents are suspecting of making their children ill with a diagnosis Munchausen by proxy, and children are taken into custody. This is a slide which is difficult to read. When I prepared for today, I sent 3 questions to the EMEA members. The first one, how many specialized clinics per 1,000 patients are there in your country? How many in-bed units? And how many years between the first signs of the disease and diagnosis? And what I want you to see is all the zeros. There are almost no specialized clinics in any country, or 1 or 2. There are no in-bed units with a few exceptions. And the years before diagnosis varies between 3 months and more than 10 years, with an average of 5 years about. Consequences. Patients feel humiliated, lose trust in healthcare. They try to work or study despite not feeling well, which leads to post-exertional malaise, which is later explained by the clinicians, and they become increasingly worse. They may develop secondary psychiatric symptoms, feel stress and frustration, which is equal to exertion, resulting in PEM, resulting in deteriorating health. They become poor, even destitute, when disability benefits are not granted. And severely ill patients in need of hospitalization are mainly cared for by family members, if they have any. But then I want to state, doctors are not evil, but without enough knowledge or support, they become helpless and irresolute when regular clinical tests do not give any information. A couple of years ago, EFNA made a survey of young Europeans with neurological conditions. And I want to focus on the responses from ME patients. In education, 15% of respondents have obtained master's degree, with ME 8%. Medication, 65% take prescribed medication for the condition, with ME 40.5%. Employment, 31% are in full-time employment, with ME 9%. Specialist care, 63% are under the care of the specialist doctor or neurologist, with ME 19%. This is a result from a Swedish survey about disability level. We asked our members how disabled they felt in different kinds of activities, ranging from strenuous activity to run, to lift heavy things, to moderately strenuous everyday activities like vacuum cleaning, gardening, to slightly strenuous, to go upstairs, take a shower, or dress. And the red bars signifies severe reduction, yellow, moderate reduction, and green, no reduction. And to the left, you see the results when it comes to strenuous activities. Almost no one can manage to run, to lift heavy things. A few says, well, I can, but with effort and difficulties. When it comes to the middle bars, when it comes to daily activities like gardening and vacuum cleaning, still some 70% say impossible. About 30, yes, but with effort and difficulties. And a few say, yeah, doable. Then when it comes to take a shower, to go upstairs, to dress, there are still almost 30% answering, no, I can't. About nearly 60% say yes, with difficulties. And less than 20% say, yes, I can without problems. They are disabled. And I want to line out a best case scenario. The patient sees a GP with knowledge about ME/CFS. The doctor makes a thorough clinical examination, listens to the patient's story, orders all samples needed to exclude other illnesses, and map comorbid conditions. Sends referrals to specialists, for example, cardiologists, neurologists, if needed. Consultation or referral to a specialized ME clinic for further assessment and diagnosis. Prescription of drugs and advice about other interventions, for example, pacing for symptom relief. Regular contact established, digital or as home visits, with medical checkup to control for additional illnesses and follow up about quality of life. Medical certificates for disability benefits and practical aids. And if needed, in-bed care for the very severely ill. And hopefully in a few years, biomarkers and cure. How to get there? Teaching about ME/CFS in all medical training and in continuing education. Establish multi-professional, multidisciplinary specialized clinics for assessment and care of the severely ill, also serving as a hub for expert consultation and supervision of primary care staff. Information to schools about the needs of children with ME/CFS. Provide information to staff in the health and social insurance systems, and of course, increased research funding. Thank you very much.
Thank you very much, Kirsten. I think you've really set the scene there in terms of what the challenges are, but also your best case scenario in terms of what can be done. And I'm pleased now to bring in the researcher's perspective and the clinician's perspective on this one. And I'll hand first to Professor Jonas Bergqvist, who is from the European ME Research Group. And Jonas, perhaps you can tell us why we are so far away from that best case scenario, or are we as far away as we might think? So the floor is yours.
Thank you, Donna. Well, just to address that first question already now, I think we are getting closer and closer to the best scenario, but we have still a long way to go because we need more research. We need to understand the fundamental principles behind this disease. And I will try to bring up a few things in my presentation that I will share with you right now here. Hopefully you can see my slides here.
Yeah, perfect.
So I was asked to talk about Merge, this research group that we have collected in Europe, and we are now trying to help each other with doing and performing the best research we can around ME/CFS. So I'm located in Uppsala University, and we're also running a clinical research center at Uppsala. And if I can change my slides here. So just to set the scene a bit, we already heard a bit this morning or this afternoon, but I want to stress something. This is a global disease. We have neglected it in Europe, but we have also a neglectance around the world, and we have to address that. We have to work together to actually understand this disease much, much better than we know today. And also, we should remind ourselves that ME/CFS is a quite common disease. It's actually twice as common as multiple sclerosis, and it can affect men, women, children, anyone, anytime, as it says here. So how do we deal with this? Well, what do we actually know today? I tried to list a few things that we are in consensus about when it comes to ME/CFS. We know that the central nervous system and the autonomic nervous system is affected in the patients, and we can connect symptoms to problems in the nervous system. We also know that the metabolism, and especially the energy metabolism, is affected in the ME patients. We know we have found altered immune phenotypes and functions, including neuroinflammation and autoimmunity is activated in ME patients. We are now doing studies in the gut microbiome, and we think that the gut microbiome may be one part of the explanation for some of the symptoms. And there are also ongoing studies when it comes to gene expression along with epigenetic changes, which is also very interesting, but still preliminary findings, I would say. Unfortunately, there's a lot of things we don't know today. What are the mechanisms that cause the disease symptoms? What leads to the changes we see in the different symptoms and systems? What links the changes, and what is the trigger or triggers? Is there a common explanation model for all the symptoms? This is what we have to address. And eMERGE, as the European ME research group, is influencing this. It started in 2015, and currently we have 24 members with 10 European countries represented. And the aim is to develop and encourage a coordination approach for ME research in Europe. And we also promote collaborations between different members, and also promote to raise the profile of ME/CFS research among stakeholders and patients. The idea is to represent a broad range of scientific disciplines and make sure that we connect the best high quality research with the fundamental technologies and techniques, but also address the key issues when it comes to understanding the background of the disease. And the groups that have been formed already are not exhaustive or not exclusive, so we are very open and welcome new initiatives, and want them to join us in the eMERGE group. So right now, last week we had a very successful colloquium. We have an annual colloquium every year with different research topics. Last week we addressed current focus on some hypotheses, and we addressed epidemiology, autonomic nervous system and autoimmunity, mitochondrial metabolic dysfunction in ME, host microbe interactions, immunogenetics, and therapeutics, both the current possible way of therapeutics use and the future use. So a number of very important and key questions are addressed within the eMERGE group. And there are already some good examples of collaborations within the different research groups with different focus areas. One example is between Uppsala University and the Cordum Institute in UK, where we have an ongoing PhD student as a cross-site working collaborator. Also between the University Hospital North Norway, Harstad, and the Cordum Institute, there's a collaboration going on. The forthcoming Restore ME fecal microbiota transplant is a clinical trial that Cordum Institute is leading, and that is also a part of the eMERGE portfolio with other collaborators around the world. And funding bids have been made by eMERGE, including a multi-international site study for long COVID and ME/CFS research, and we are waiting for the decision on that matter right now. So what I want to stress is that eMERGE, as one of the partners within the research area of ME, together with EMEA that Kerstin just presented, and what we soon will hear from Christian about EMEC, the network of clinicians, the Clinician Council in Europe. The connection and the collaboration and the openness between these different organizations are extremely important. And that is going to be the research success, I would say, for this disease. So collaboration is the key, and I thank you so much for your time and interest. Thank you.
Thank you very much, Professor Bergqvist. And it's really heartening actually to see already the links between the patients, the researchers and the clinicians, because I think in other disease areas that has been a major barrier to progress. But I think here in the ME community, you've already got that in place. And I think that's a great starting point. I had one quick question for you, because you said collaboration is key. How important is funding? How far could you go with more money? Is that what's needed here, or is it just part of a bigger picture?
Unfortunately, I have to say that economy is controlling a lot of things. I mean, it is, of course, the basic ground for that we can hire people, hire talented students for doing collaborative research and so on. But still, we need also to be attractive to researchers to get into the field. And I think, unfortunately, their economy comes in there also, but also availability of biological material, biobank samples, technologies that we need for addressing certain questions and so on is going to be key issues. So it's a combination, I would say, but research funding is very, very important.
Thank you very much. So let's jump on quickly to then bring in the clinician's perspective, because I think Kirsten raised a lot of issues around that relationship between patients and the doctors. And it's my pleasure to invite Professor Christian Sommerfeld from the European ME Research, the Clinicians Council, sorry, to address this part of the meeting. So Christian, the floor is yours.
Thank you so much. I need to share my slides. My name is Christian Sommerfeld. I'm a professor of pediatric neurology, and I would like to present the clinical aspects. I'm going to focus first on features of the disease that I think is important for why there is such a noise around this disease and disbelief. First, the main obstacle that is holding us back regarding both clinical improvement and research is the lack of recognition that the disease exists at all, and also the severity of the disease, as Kerstin Heiling very beautifully illustrated just now in her speech. The basic features is, I will not dwell on this, 80% starts in the weeks after signs of an infection. The prevalence is 1 out of 200 approximately, and the beginning of the disease starts in 12 to 19 years of age or 30 to 40 years of age as two peaks. Main feature is extensive fatigue, post-exertional malaise. We heard about that described from Kerstin. Brain fog. They cannot continue a conversation, for example, without feeling that something is stopping them from a given time, and the patient knows how long that time is. Inappropriately warm and cold, autonomic symptoms, pain, not always, usually, headache, muscle aches, abdominal pain, and light, sounds, hypersensitivity, sleep disturbance, and most of all, the importance of a definite reduction in total activity level, the things they're able to do in their life. It needs to be below 50, typically 10 to 20% in mild to moderate ME. So the disease invisibility is the main problem, because usually it's completely unbelievable that the patient or next door neighbor with ME has such a disease. Typically they seem unremarkable when you meet them, and they can push the time they are unremarkable when with other people. And the more they push, the more they will be punished with pen later on. In other words, when you see them, they look normal. When they are too sick, you don't see them. They're at home. The most sick, 5% or something, they are never out of the bed or the house. You never see them. In other words, you don't see the disease. And of course, you don't have any biomarkers or tests where you can say this is the disease yet anyway. Also, a very important feature is that the coping of the patients of the disease, which is very brave, in itself hides the disease. When you ask an ME patient, how are you doing? They often say, I'm doing fine. And when you ask, what's the main problem? They sometimes don't know what to answer. They may say, well, it's that I have a pain in my back. And they don't even mention that they are at 10% level of activity and have extensive fatigue all the time, because it had lasted, been like that for a couple of years, and they have forgotten normality. And they don't focus on abnormality. They focus on what is similar to normal life. That makes it also invisible. So where is the disease visible? That is most of all in the completely abnormal possibility of participating in activities. And the patients often overestimate what they can do, also because of their positive coping style. So you cannot even trust the patient saying that they are with friends every other week. That may be every other month if you get comparative information from other people in the family. also regarding assessment of what they actually are able to do. It's a better, a more precise evaluation of that from other family members, parents, spouse, etc. School children, that's very interesting, because below 15 years of age in Norway, below 15, 16, school is compulsory. In other words, they have to be there. If they're not there, then something happens. Parents, teachers, doctors, they react, something is wrong. So they are brought to the doctor, brought to the pediatrician, and hopefully the disease is diagnosed. And that means that it is a possibility to identify the disease because of the compulsory school. In other words, what is happening below 15 years of age in European countries? I'm very interested. Which diagnoses are given? Where are those that are over a long period of time, not normal amount of time in school? Probably ME is the most important reason for long-term school absence. Of course, also in school after 15, 16, but that's not compulsory. So then they may just disappear, as grown-ups often do with the disease. Now, that has been a major focus in Norway the last 3 years, with the development of a special course, 2 hours for school, where the people from the school, parents, patient maybe, general practitioner, participate after the diagnosis has been given. That course is also usually taken in the school. And the teachers, the school, all the people working in school, they get to know ME because they have typically 3 patients in every school. And what has happened now is a situation where those that know the disease and recognize it first, that is the school. Next best is the general practitioners, and the definitely worst is the special health services, the hospitals, etc. They usually don't understand the disease. They have no system for handling it typically. That's even in Norway, where it's probably better than in most countries in Europe. So why is that? Well, in school they knew the child, the adolescent, before this happened and afterwards. So they see the difference. The same thing often with the general practitioner. While in the special health services, they don't see the patient. They didn't see him before, and afterwards they have a very limited follow-up usually, so they don't get to know the disease well enough. So I think it is very important to focus on what's happening in school, as that may be a laboratory for what is also typical in adults. Features of the disease make it invisible. So I hope that there can be an improvement in other countries in Europe regarding recognition in schools. Denmark is following. They are using this new course. Sweden is following. Finland is following. And I would very much hope that it is spread further around Europe. But it also needs to be done exactly the way Kerstin Heiling said. It starts with medical education, and it continues with giving responsibility for this cruel disorder to a specialty in specialist healthcare. That has not happened. Is it neurologist? Is it internal medicine? What is it? That's not been defined. So we need to take responsibility for the number of people and the severity of the disease. Thank you.
Thank you very much, Professor Sommerfeld. And I think you've really captured an important point here, in that sometimes as patient organizations, we are guilty of overlooking this younger demographic, and we probably need to do a better piece of work in terms of looking at the needs across the generations, and this intergenerational aspect of neurological disorders, and ME clearly could be an exemplar in this space. And maybe continue going back to our discussion later on this afternoon. I'm going to move now, in the interest of time, and we'll take up some of the questions that are coming in before the break, but I want to move on to Fred Desterbeck, who is the Executive Director at the European Brain Council. And the European Brain Council brings together those groups that we've just been hearing from, so the patients, the researchers, the clinicians, to work in this wider sort of brain space, so covering both neurology but also mental health. And I guess, Fred, what we wanted maybe to hear from you is how you as EBC maybe bring those different disciplines and stakeholder groups together, what some of the projects maybe and activities you're working on, and how you see sort of that model or those activities being applicable or appropriate for engagement with the ME community. So Fred, you've got 10 minutes and the floor is yours.
Thank you very much, Donna, for the introduction, and thank you to you and the organizers, to Richard, for inviting me to provide this this perspective. Next slide, please. I'm actually pleased to present on behalf of EBC. So EBC, we are a multi-stakeholder platform, multi-stakeholder organization, representing different organizations in the brain space, typically patient organizations, and obviously EFNA is one of the founding member of our organization, together with other scientific societies like the European Academy of Neurology or the European Society for Pediatric Neurology, amongst others. And we also collaborate with industry partners as well as with national brain councils in order to advance our agenda. Next slide, please. So in terms of our agenda, the purpose of EBC and the rationale for setting up the organization, it will be nearly 20 years ago now, was to promote and expand brain research in Europe. We have done that through the adoption of various documents that we called consensus statements, the last one being adopted in 2016, and where we were actually fleshing out our recommendations as to what priorities the European Commission should set forward in funding and supporting research into the brain at a European level via the mechanism that were explained earlier on by Catherine Behrens. Next slide, please. So the reason for us to do so is actually very plain, is the fact that according to evidence released by WHO, more than 1 in 3 Europeans will be living with a brain condition. So the estimates that were released are in the range of 38%. I know that there is much work being done now on revisiting those figures, but the, let's say, published evidence refers to this one, 38%. So that means an estimated 179 million citizens over the European Union, but also this human burden comes with an economic cost, and this cost was estimated to nearly 800 billion euros every year, being the management of brain conditions across the EU. And so this is evidence that EBC released in 2011 in the cost study on brain disorders in Europe. Next slide, please. So actually, on the basis of this evidence, what we wanted to do was also advance concrete recommendations. So we have done that in the context of various projects. One that was quite emblematic, it started in 2015 and still ongoing, is on the value of treatment for brain disorders, and actually a continuation of the custody of 2011. We wanted to really investigate what the impact of non-treatment actually related to, in the sense that this cost should rather be seen as an investment, and not investing into the management of brain conditions would actually create harder consequences for society. So the recommendations that we came up with were really around the topic of timely intervention, but also it was an opportunity for us to re-emphasize that more research was necessary, because we are still failing to have proper cures for most brain disorders, and hence the need to continue to focus on what basically we can act upon, like risk reduction, stigma prevention, early detection, and, as I said, increased funding for research. Next slide, please. So what we did already also, aside this value of treatment policy paper, was to work on a country level, or let's say nationally validated recommendations, if I can put it this way. So we took with some of our case studies, and you can see on the right-hand side, we worked on the recommendations in the field of multiple sclerosis, where we released a report entitled Rethinking MS. You may have come across news in our social media and digital platforms about this report. It was released 2 years ago, and we have now a new version that actually relates the impact of COVID-19 for people living with MS and for people looking after them. The idea being that here we wanted to really tailor the recommendations we made at a kind of EU overarching level by doing a country analysis and country profiling and making sure that our message was fit for purpose and ready to be used for national and local actors or stakeholders and policymakers. Next slide, please. So I'll have a quick word just on the work that we have done very briefly at the national level. So we have this long-standing call to action at TBC, that this work with our national brain councils is really there to be nurtured by this idea that we need an overarching European action plan or European initiative, but that would resonate or be able to frame action that needs to be done and conducted at the level of the member states. Because as it was already mentioned, any change in the organization of care can only happen nationally. So what we really are trying to now put together is this phenomenon of, or this synergy between the EU action and the action at a national level. Next slide, please. And we would like to take as an example what happened in, ironically, a non-EU member states, but in Norway. So they launched in December 2017 what they call the National Brain Health Strategy, which was really a 6-year work program to really implement in various phases their strategy for early detection, but also to reduce the impact of brain disorders on society as a whole, and to accelerate science in the domain. So other countries are now following up, like Poland. Belgium is also doing quite a bit of work on that, but this is really a long-standing effort, and we actually are in need of greater policy support in that respect in order to make it happen more widely across the EU. Next, please. So I just would like to pause here in my presentation to just remind concrete developments that have happened. I said recently, but it's already a couple of months ago, but you know that we now have this US imported custom to have a State of the European Union address by the President of the European Commission. And so Ursula von der Leyen honored EU citizens of her wisdom a couple of months ago in the European Parliament. But what needs to be noted is that it was the first time ever that health was recognized as one of the key priorities for the action of the European Commission. Given the fact it's not a competence or direct competence at EU level, it was always disregarded. I think that from the COVID-19 pandemic, they could definitely not shy away from addressing it. And the least we can say is that there was really an ambitious attempt to try and address the impact of COVID-19 with this idea of developing a recovery program with increased investment in research, notably via the Horizon Europe program. But also, and I think above all, there was this call to create a European Health Union. And we now have an unprecedented funding mechanism in the field of public health and health in general with this EU for Health program. And thanks to the action of EFNA in particular, we have the recognition of brain disorders and particularly neurological disorders as being one of the key priorities that need to be supported via this program. So it's, I would say, only a couple of billions, but it's already many more than what was initially planned. And we cannot omit that this is really a window of opportunity. I know, Donna, you would like to address this later, but I wanted to make the point that this kind of post-COVID era is definitely providing a window of opportunity, and it was clear also from the address of Dr. Tedros. Next, please. So when it comes back to our field and the action of EBC in this context, the messages that we try and emphasize in this context, and as I mentioned earlier, with the few figures I mentioned, the burden of brain disorders is immense. If we combine neurological and psychiatric disorders all together, we are the #1 by far, and the situation is clearly worsening with COVID-19. There were already a lot of concrete recommendations that were formulated, but as I just said, we now have a new window opening up to re-emphasize and refocus on these issues, as they have never been so important. We also need to recognize that there were innovations made possible thanks to the pandemic. We had new funding mechanisms. We had accelerated clinical trials in order to develop vaccines, but also now to develop treatments against COVID. So clearly, we need to get inspiration from those innovations in order to advance our agenda. Next slide, please. And I just would like to come back to this by quoting two examples. And I know that my time is running short, so I'll be quick on that. One is a policy paper that EBC did release in March on brain health innovation. So the title is, as you can see in the right upper right corner, Brain Health in Europe, Fostering Innovation, Improving Outcomes. We had 4 pillars on the prioritization of brain health, fostering research and innovation, improving outcomes, and access, and implementing an integrated approach that really revolves and summarizes the action that EBC wants to take. And next, please. I just wanted to finish off with a word on this EBRA project, as it was mentioned by Catherine Berens earlier. So EBRA stands for the European Brain Research Area. It really aims at bringing together all the large-scale initiatives that were already mentioned earlier, with this idea to streamline the action via 2 ways. Next slide, please. So what we wanted to achieve was to avoid fragmentation, create connections, and define shared priorities. And on the next slide, normally we have the 2 ways of action. No, sorry, it's not there. So we have 2 ways of action. One, it is strategic. So by redefining the agenda for the future priorities on brain research and brain health in the framework of the next phases of Horizon Europe. So it's really an attempt to shape the Brain Health Partnership, but also not only, so all action of the framework program needed to really be captured by the community. And what we would like to achieve is to come up with again, a consensual outcome of this consultation mechanism that we will be launching in the coming months. So here is really a plea to work via your member organizations and notably via EMEA and EFNA in order to make sure that your priorities and your concerns are being integrated into the approach that this document is going to take, as it's going to feed directly into the strategic thinking and brainstorming of the European Commission and the member states in the definition of the future lines and future priorities. So I'll end up there and send it over to you, Donna, please.
Thanks, Fred. And I know you're staying to the panel discussion later on, so we might come back to you on some of those initiatives that you've mentioned and talk a little bit more concretely about how this particular community of stakeholders working in the area of ME could get more actively involved in some of the activities there. But we've got lots of interesting presentations coming up in the second part of the meeting today, where we'll be looking at that link between long COVID and ME, and also then taking a look at some really positive national examples of when things can be done well and what we can learn for other parts of Europe and beyond. So it's now my pleasure to hand over to Dr. Tomislav Sokol, MEP at the European Parliament, who has been really a friend to neurology since his election. And Dr. Sokol, if you're with us now, we'd be really eager to hear your perspective on what the European Parliament can actually do to help disease areas like ME make its way onto that public health and research agenda. So the floor is yours.
Thank you very much. I would first like to thank you for inviting me, because I think it is very important that during the COVID-19 crisis, we also maintain dialogue about other health issues, which are very important, and to use this kind of a momentum that we have on European level, where healthcare is becoming one of the policy priorities of the European Union, to really shift focus on the other areas like neurological conditions as well. First, I would like to emphasize I am a doctor, but not a medical doctor. I'm a doctor of law. I teach health law. I'm a member of the European Association of Health Law, and I've been acting as an advocate for health issues in the Parliament, as you said, since my election, and especially through the Special Committee on Beating Cancer, which is one of the flagship initiatives of the European Union in the area of healthcare. So first, in the beginning, I would like to, I will speak more generally about European Union role in the area of healthcare policy. I think that is important, because we in many cases, we speak of things that European Union ought to do this, or European Union ought to do that, but without actually referring to what concrete actions you can really do, can really conduct. So what I will focus on are regulatory and financial instruments that EU has at its disposal to tackle health issues on European level. But first, I would like to emphasize the fact that healthcare is still primarily national competence. So member states are in charge of financing and organizing their healthcare systems, and the European Union can only support national action. So European Union cannot harmonize healthcare standards, way how healthcare is provided, ways of financing of healthcare, but they can only provide help, financial and otherwise, member states and their national healthcare systems. And unfortunately, this was in the past being used as an alibi not to do a lot. But ever since the European elections and the initiative to have beating cancer as one of the policy priorities on the European level, and now, of course, with the COVID-19 pandemic, healthcare has really shifted from margins, where it was before, to really the center of European Union policy activities, which I think is very important. So when we discuss different instruments of how European Union can influence healthcare, so first I would like to mention the funding possibilities, because they always seem most attractive. And of course, when we speak of funding for healthcare, the most important change that we have at this mandate is the EU for Health program. So EU for Health program was adopted several months ago, and this is the first self-standing European Union program in the area of healthcare. So before we had the previous health program in the previous 7-year budgetary period was part of the European Social Fund, and it only amounted to 450 million euros. Whereas the new program amounts to 5.1 billion euros, so it's 12 times bigger, and it's a self-standing program with its own set of policy priorities, initiatives, etc. So when we speak about EU for Health program, so it has 4 general goals and 10 specific objectives. So first general goal is to improve and foster health in the Union, and focus here is on disease prevention and international cooperation. So this is the first. Second is to tackle cross-border health threats. This is very important because EU can act in those areas where member states cannot resolve issues on their own. And of course, cross-border health threats like the COVID-19 pandemic are especially important in this regard. 3 is to improve medicinal products, medical devices, and presence relevant products. This is very important because this addresses a very important issue of how to make affordable medicines available to the entire European population. When you know that we have different big problems across different member states, different costs of expensive medicines, different funding priorities. So this is something which represents a big problem. So European Union can do a lot, I think, in this regard through joint procurement, which can be used to reduce prices, but also to provide financial help also to member states in order to tackle, in order to provide more these and make these medicines more affordable. And finally, to strengthen health systems, their resilience and resource efficiency, and access to healthcare, especially equitable access to healthcare, here is one of the priorities. And I think this is important because when we speak in general, there are still enormous differences across the European Union in terms of providing access to quality healthcare. And there are much bigger chances of dying from certain disease in Eastern Europe than in Western Europe. And this is something that needs to be changed. So this is something that needs to be tackled on European level. And EU for Health program is one of the instruments that can be used to do this. So this is more or less about EU for Health, and also there is Europe's Beating Cancer Plan, which is also very important. Which it's not a separate source of funding, but it combines the existing sources of funding. But what is important there is that Europe's Beating Cancer Plan is the first plan which systematically covers everything from prevention, early diagnosis, treatment to afterlife and the quality of life of cancer survivors. And I think this is also something which is a big step forward in terms of providing this more systematic approach to Europe's action in beating cancer. Then there is Horizon. Obviously, Horizon is one of the program for funding research and development on the EU level, and here beating cancer has become one of the priority missions, which means that a lot of funding for European projects where different institutions compete against each other, different research institutions will go for the purpose of funding cancer research, and also other related research in the area of healthcare can also be financed from this source. And finally, there is the cohesion policy, which is around 1/3 of EU budget, which is there to reduce inequalities in terms of economic development. And of course, in this sense, this also relates to differences in terms of health outcomes and differences in terms of access to quality healthcare. And EU cohesion policy can be used to fund the procurement of medical equipment, building of health infrastructure in those areas where we have a lack of these, where we have a lack of top quality hospitals, top quality medical equipment. So EU funding from cohesion policy can be used to finance this in the health infrastructure in less developed regions to reduce these inequalities that exist in the European Union today. So these are all funding possibilities that EU has at its disposal, which are without precedent. So the EU budget for the next 7-year period will be without precedent in terms of its size. And of course, healthcare will become more important in this funding than ever. So this was about funding, and of course, we speak of, so that's one part. And of course, the other part is also regulation, regulatory framework, where I said that European Union cannot harmonize national legislation, but it can provide help and resolve problems which member states cannot resolve by themselves. So first, what I would like to mention, one important initiative is the European Health Data Space Regulation. We know that that exchange of data between different member states is very problematic. There is no interoperability of this data. There are problems of different interpretations of the GDPR. And of course, in this sense, the new Health Data Space Regulation, which should be come out by the beginning of next year, we'll have to change this. And this will be very important to facilitate the use of European reference networks for rare diseases, but also to make it possible to conduct clinical trials in different member states much easier than before, which is also, I think, connected with our topic today. So there is also cross-border healthcare directive, which is still not utilized to its full extent. There are still many obstacles to patients who want to access healthcare abroad in cases that adequate health treatment cannot be provided in their own national territory. And in these cases, definitely, this directive needs to be improved, more simplified to reduce these obstacles that patients have to face when accessing healthcare abroad. And I think that the revision of this directive in the next couple of years is very possible, and currently there is a public discussion going on how best to address this. There is also HTA regulation, health technology assessment regulation, which is also should be big help for national health insurance institutions in order to provide one-stop shop, so that not each member state needs to conduct its own health technology assessment, but to have one common system which can be then used by all the member states, similar as we have with the EMA for approving of medicines. So using this HTA on the European level should definitely facilitate introduction of new medical technology into national healthcare systems and make it easier for national healthcare systems to use this without having to conduct their own health technology assessments each time. This regulation, I think, does not go far enough, but it does not provide for cost effectiveness analysis, which will remain national prerogative. But I think even without this, that adoption of this HTA regulation will be a big step forward. Let's hope the Parliament has given its position. Let's hope that in the end, the member states and the Council also can make an agreement on this. And there are other related pieces of legislation that EU is working on. There are also some existing pieces of legislation, like the Transparency Directive for introducing new medical technologies into national health insurance packages, social health insurance packages, which has not been amended for more than 30 years, which definitely is also important because it's absolutely obsolete. There are big differences in terms of how member states decide on what types of treatments, medicines, etc. they will fund from their national health insurance funds, national health insurance institutions. And of course, new legislation here will be also required. But again, the same problem as with most EU legislation in the area of healthcare is that member states have a hard time agreeing on common solutions and common compromises on what to do on the EU level. So to sum up, European Union's competences in the area of healthcare are very limited. Primary responsibility for organizing and financing of healthcare systems is on the national level. However, EU has a wide range of financing and regulatory instruments at its disposal to help member states improve their health outcomes and healthcare provision, to reduce inequalities between different member states in terms of healthcare provision, and to resolve those problems which member states cannot resolve by themselves. And now we have a great opportunity to utilize all these possibilities on EU level, and I can promise you that healthcare in this sense will remain on the top of my list of priorities in this term in office. And of course, what is very important, as I said in the beginning, is not to focus only on COVID-19, but now that this pandemic is coming to a close, hopefully, to shift focus on other areas of healthcare to really make a difference in all these other areas, in all these other issues like neurological and mental health conditions, which are also very important and create big problems for a large part of European society. And definitely, I can promise you that you will continue to have an advocate in the Parliament for myself. So thank you very much, and I'm open to questions and comments.
Thank you very much, MEP Sokol. I think you've given us a real whistle-stop tour of all of the policy dossiers that are on the table within the European institutions today. And I think we really need to take a listen again to your really in-depth presentation and to see perhaps where this community could really sort of get involved and those policy hooks that those affected by ME could really use to advance this particular agenda. But there's certainly a lot of activity happening in the public health space today at EU level, thanks, I guess, to the pandemic, and a lot for us to think about in terms of how we position ourselves there. So thank you very much for setting the scene from the Parliament's perspective. And I know some of your colleagues have also joined the meeting today, and if any of the other MEPs in this virtual meeting room would like to take the floor at this point to add to what MEP Sokol has had to say, please feel free to unmute and to jump into the discussion. We'd be very happy to hear from you at this point.
So I could just shortly jump in.
Please.
My name is Ladislav Ilčić, and that's the first time I met this subject, so I will listen very carefully, and I hope that is not also the last last opportunity to meet. So I'm listening, and I understand that it's very important topic. Thank you.
Thank you very much for joining us. And we also had MEP Chris McManus with us for the earlier part of the meeting, but he had to leave for another appointment, but again has also promised that we can follow up with his office with the meeting report and next steps. So it's wonderful to have such MEP support for the meeting today. Thank you all for being with us. So let's move to the next part of the meeting, which is the discussion around the links between long COVID and ME, and to discuss a little bit more about how we could perhaps link into this theme from both the scientific but also from the policy perspective. And I'm pleased to welcome Dr. Beata Della Jaworska, who is a representative from both the ME Research Group and also the ME Clinicians Council. And Beata, I believe you are going to give us some insight from the front line in terms of what you're seeing and the similarities that you have picked up in your work between ME and long COVID. So Beata, the floor is yours.
Thank you very much. So starting again, I work for the CFS ME services in east of Anglia. We cover about 2 million patient population. From the beginning of the pandemic situation, we were really wondering about what will happen in the terms of the patient being diagnosed with COVID and obviously presented with a long-term problem with the fatigue. As far we know, it's worldwide, we got approximately 174 million patients reported on the 7th of June, and I just checked today, is another million patient added to this. Of course, this only includes patients they got a positive test, whether it was through the swab or antibody test. And we noted the worldwide cases of COVID-19, they will be probably significantly more, approximately is estimated even that the figure could be up to 10 times higher. We are thinking about long COVID, how many patients from this group will develop long COVID. And it's estimated that in 6 months, approximately 10% of all patients with COVID will continue with COVID, will continue with lingering symptoms of long COVID. At the moment, there are really few research across the world, including the UK, including Ireland, Italy, many in America and Scandinavian countries, to find out the answer about more information about that statistic. ME CFS, we estimate that it could be even up to 5% of patients affected with COVID may present with long-term problem. And this actually may happen regardless of the severity of the symptoms initially. So the patient who presented with relatively mild symptoms still may end up with long COVID, lingering symptoms, and finally turn to classical presentation of ME CFS. Post-COVID patient, obviously, we get this discussion before that many patients got lingering symptoms for 3 months, approximately 35%. For 6 months, 10% up to 12%. But for many patients, unfortunately, symptoms will continue over 1 year and presented with overlapping ME CFS. The most common symptoms of lingering long COVID syndrome are fatigue, aches, chest-related problems, short of breath, chest pain, cough, heart problem, but very commonly cognitive dysfunction, headache, sleep problem, autonomic dysfunction symptoms, PEM. And we all clinicians who dealing with CFS ME for numbers of years raise the question, is this familiar? It sounds familiar. Is this another ME or very similar problem to ME? COVID versus ME. we all know, but I would think that it's important to emphasize that many CFS patients, they got problem after having infection. Of course, glandular fever is one of the most common. Flu, Lyme disease, borreliosis, of course, coronaviruses, SARS, MERS, COVID now, Ebola virus, but bacterial infection, Mycoplasma, Coxiella, and many others. Of course, we estimate that COVID-19 will lead to, and we already know that it leads to long COVID syndrome, but finally it would be significant overlap with ME/CFS. And from my clinic, the patient I already met since November, I saw first patient with long COVID with overlapping CFS symptoms in November. They really presented with classical symptoms of ME/CFS. So I would think that many clinicians now think that long COVID is very similar or almost the same as ME/CFS, or at least ME is overlapping with long COVID syndrome for many patients. What is the future? It's estimated that 1 in 10 patients who get diagnosis of COVID, who develop long COVID syndrome finally, will continue with the lingering symptoms over 1 year. And this is really what I already can see in my CFS ME clinic, and I think most of the clinicians will agree with this. ME/CFS services are overstretched. I can, of course, say what happened in the UK, in the country that I worked for 16 years. But we hope that more publicity of ME/CFS as a result of the pandemic will raise awareness in the worldwide community and hopefully will lead to more research funding to help our patients. So this is what I would like to summarize, that we all waiting for that tsunami of the patient, but of course we would like to help them, but we need to get tool and we need more research, more funding for this problem to help our very affected patients. Thank you.
Thank you very much, Dr. Jela-Jaworska. I think you've really, I suppose, convinced us that there is that link between ME and long COVID, and that potentially this is an area we really should be looking at a little bit more from certainly from the scientific research and medical angle. But I also wanted to build on your presentation and now bring in a policy perspective in terms of what we might be able to do in positioning ME in policy discussions around this particular topic. And it's my pleasure to invite the Non-Communicable Disease Alliance to today's discussion. And Tolu, that's what I'm going to call you because I'm not going to attempt to pronounce your full name. I would invite you to take the floor, and you've got maybe 10 minutes to tell us what NCDA has been doing in this space, and maybe your suggestions on how ME could benefit from this and leverage some of your work at the international level. So the floor is yours.
Hi everyone, that's totally fair. I wouldn't also torture you by asking you to call my surname, but it's a delight to be here among these distinguished panelists, and it's definitely been a learning opportunity for me. And so I'll quickly build on the solid work that Beata has just done in explaining sort of some of the clinical features that we have seen so far in terms of long COVID and prevalence. And I'll share my screen now, of course, I have a couple of slides to guide us through. Yeah. So I'm conscious that we spent some time editing the slides, so I'll just maybe go into the next slide, Richard. Thank you. So just to share what we do at the NCD Alliance for colleagues who might not be familiar with us, we are a civil society. We have global presence with members who work from 81 countries. We currently work with 300 member organizations like I said, from 81 countries, and our work is implemented through 66 national and regional NCD alliances who sort of support the work we do at the global level and translate them into action at the national and regional levels. We were founded just 1 year after the EMEA in 2009. And we work with a diverse range of stakeholders. We definitely understand the role of the whole of government and the role of society response to NCDs. And so we have partners across the private sector, foundations, academia, and NGO. We have offices in London, Geneva, and New York, and we are about 21 in number on the NCD Alliance team. Next slide, please. Yeah, I would like to also share that obviously, given the fact that COVID has impacted on the work that we all do in one way or the other, we have just launched our strategy for the next 5 years, which very much takes into consideration the impact that COVID has had on our work as a community. And so this strategy obviously upholds our strategic pathways on advocacy and accountability, capacity development, knowledge exchange, and partnerships. And maybe just to reflect a bit more on advocacy and accountability, we understand our role as a global convener of civil society movement on non-communicable conditions. And we like to optimize opportunities to talk about not just the main 5 NCDs, main 5 because they account for the greatest number of deaths, but we also very much engage with communities that have not been properly recognized at the global level. So we work with communities, that work on non-communicable skin conditions. We work with communities that work on bone health. We work with EFNA, for example, and by extension, we are here today to support this meeting organized by EFNA and EMEA. So we are very much appreciative of forums like this that bring attention to not just the 5 NCDs, but also the important, rapidly evolving topics, for example, on ME and long COVID, which I will talk about shortly. Next slide, please. Now, around January this year, we took note of the rapidly evolving messaging on long COVID. We observed that there was more and more evidence that this was becoming an important issue to keep in view, and we took the initiative to develop a briefing note on long COVID. As you would be aware, long COVID-19 itself has impacted on people living with NCDs significantly. We know the majority of deaths from COVID has been among people living with NCDs, and beyond that, we understand that it has impacted it has caused significant disability, it has caused significant pain to people living with NCDs. So we thought it would be important to reflect on, this rapidly evolving long COVID issue and, sort of proactively inspect the impact it might have on people living with NCDs, their access to care, and the way they go about their life, haven't been at the risk of COVID-19. So in this briefing note, we discussed, a definition for long COVID, reflected on the prevalence, the symptoms, and the impact on people living with long COVID itself. And then we took some time to reflect, to compare long COVID and NCDs. And obviously we saw similarities in some of the most common symptoms. And, having followed today's discussion, I also noted that, long COVID and ME have so many symptoms in common, and long COVID might as well, be, ME itself, that, but obviously we are still building evidence. So time will tell, eventually where this lands in the global, health agenda, even as we move forward. And then we looked at the health system gaps, that have plagued NCDs so far, and the implications for care, particularly noting that, like Beata has just said, we're expecting that there will be an increased number of people who actually need care for chronic conditions. And finally, we offered some policy recommendations, including on care, on health system planning, and on meaningful engagement of people living with long COVID. Next slide, please. So for the next few slides, I'll just maybe talk briefly about the key messages we shared in the briefing note and some of the policy actions we recommended. And so, like I said, we looked at the prevalence, which is quite staggering. And we understand that COVID-19 cases are currently over 170 million. And if we do a straight calculation, based on the 10% prevalence of long COVID, we see that, we might be looking at 10, 20 million people who are currently living with long COVID. And we also noted that many of them are, older people who are currently, would expect to have some level of reduction in their functional capacity. And this was a major concern to us. But I think I should also share that, beyond older people, we also noted that long COVID was not sparing any age group. We understood from research that young people, teenagers, people who were otherwise healthy before they came down with COVID-19 were also reporting cases of, prolonged feelings of illness and disability, over 12 weeks after, they seemed to have, recovered from the COVID-19 infection. So, all of these things, sort of shaped our thinking around how best to position policy responses to long COVID. We also reflected on, the past coronavirus cases, for example, the MERS and the SARS that Beata has also pointed out. And we noted that definitely illness after infections are not new. I'm sure we all know that, but we noted that for long COVID, it appeared to be affecting a broader range of organs. And based on the scale of the pandemic, more people, were reportedly, coming up with long COVID conditions. So we looked at all these things and, and then reflected on the fact that, up till date, we've noted that there are significant shortages in the provision for NCD care. As we go from population to population, the level of care that people have access to for prevention, for treatment, for management, even for palliative care, we see that there's a wide there are gaps that need to be attended to urgently. And so one of the first policy asks that we actually communicated was that health systems need to be better positioned to protect populations. And then we requested that adequate human and financial resources should be mobilized for health systems planning. And the thinking behind the first point was the fact that COVID-19 actually plagued on people living with non-communicable conditions, not just the main 5, but like I said, people living with cases like ME already. And we thought that it would definitely be important to keep their needs that have not been met adequately in view, while we anticipate the needs we would have in the next couple of months or years, even as we continue to work to put the pandemic under control. So all this shaped our asks, around the need for adequate funding, adequate human resources, for health system strengthening, even as we continue to battle the pandemic. If I may have the next slide, please. Thank you. In our second key message, we put people living with NCDs, in the context of long COVID. What we know so far is that, when people come down with non-communicable conditions, there's definitely there are often some reduction in the capacity of their organs to function. And we sort of imagine how stressful it must be to then come down with long COVID in addition to this. And we thought, it would be important to anticipate that beyond, the routine care that they would normally need, there will be need for, specialist care, there will be need for, there will be need for provision to be made for, in terms of the care they will need, to manage these comorbidities that could emerge, even as they manage long COVID and NCDs. And then we reflected on, that there will be need for not just acute care, but long-term care, not just for prevention, but including rehabilitation and psychosocial support. We know that COVID has, impacted on the mental health of so many, particularly people living with NCDs, who have had to, live in fear because of the risk that that we all know they have been due to the COVID-19 pandemic. So we use this second message to bring attention to the fact that we anticipate the need for not just acute care or primary care, but for specialized care that would really take into consideration the evolving needs of people living with NCDs and long COVID, and aim to support them through their journey. And you know, the key recommendations here build on the first two that we made in terms of health system strengthening and more funding and more human resources. In the second key message, we called for specific focus on long COVID and its impact for health systems. We know that governments are working through their pandemic preparedness and response plans. You know, they're looking for how to build back better and fairer. So we thought it would be a missed opportunity for them to not anticipate the burden that long COVID would place on health systems, either directly or indirectly. And we thought it would be important to encourage, you know, policymakers to prioritize long COVID, keep it in view, and plan for it, even as they work towards putting the pandemic under control. We also called for training and support for multidisciplinary teams. And what we know from NCDs is that there's need for multidisciplinary teams that work around the care of the patient. So we also seize the opportunity to bring that into focus also on that key message too. If I may have the next slide, please. And on that message 3, we looked at the surveillance gap, surveillance systems, research, UHC, and data gaps, which have plagued, you know, the response to NCDs so far. And we saw that, you know, these were also being repeated, you know, in the case of long COVID. So we used this third point to focus on the fact that COVID-19 continued to dominate meeting agenda with very little consideration for long COVID. And we asked that government should also, while mobilizing funds for long COVID, to look at COVID-19, to look at long COVID, and to understand that it's not just, not like Beata has said, there will be cases that were not diagnosed. You know, there will be cases that were not confirmed with positive tests to the COVID-19 virus. There will be people that, you know, never had to go to the hospital, but who have come down with long COVID in one way or the other. So we called for sort of a proactive surveillance system that would be able to identify people irrespective of what their COVID-19 infection experience was and where they may be all over the world. And we called for strengthened data systems that can, you know, better support governments to plan for care for NCDs and long COVID. If I may have the fourth slide, please. And finally, under the fourth key message, we called for a meaningful engagement of people living with long COVID. Part of our work as NCD Alliance is to give a platform that elevates the voices of people living with NCDs. And we thought it would be a missed opportunity to not carry people living with long COVID along, even as governments begin to react to long COVID and its implications for health systems and health financing. So thankfully, the long COVID movement is growing in leaps and in bounds. They've shaped their key asks into 3 simple words: recognition, research, and rehabilitation. And I think from Dr. Tedros's notes earlier in the meeting, they're also asking for better communication, which I think is really critical. And so we re-echoed this key ask, you know, in this briefing notes to policymakers. And so we asked that, you know, research work should definitely incorporate the expertise of long haulers, you know, even as researchers look to shape policies and, you know, find solutions, you know, that can help to support rehabilitation and treatment for long COVID. And again, we repeated, you know, the call for recognition and research and rehabilitation. So this is like an overview of the long COVID briefing note that we published just ahead of the World Health Assembly. It's available on our website, and the slides will be shared with you so you can have a better view of the discussion that I just shared. Thank you very much for the opportunity again.
Thank you, Tolo. Really interesting. And I guess we can circulate the full briefing document to everybody today, because I know there's a lot of content trying to squeeze in a short space of time. One question for you that has come in on the chat, it's, you know, we're talking a lot today about the link between long COVID and ME, and this is a roundtable to discuss ME CFS in particular. And I suppose there's a concern that, you know, long COVID may monopolize the agenda, and actually conditions like ME that have traditionally been neglected will be pushed even further to the sidelines. As a group that represents, you know, non-communicable diseases broadly, do you have some advice in terms of how we can maybe leverage this particular focus on, you know, these similar syndromes, but at the same time not get lost in a really big topical issue?
Yeah, thank you very much. I think it's a very valid question. I would like to say that I think that we're on the right track. I'm particularly impressed by the response of the MEPs that have joined us today. Definitely, there's a level of connection between the work that the ME Alliance is doing and, you know, the interest of the MEPs. So I think that this is one thing that we can continue to leverage to ensure that, you know, there's focus on ME even as we go forward. And another thing that I could maybe highlight is the fact that there are different forums, you know, such that operate at the global level. There are global meetings where, you know, there's an opportunity to shape the agenda. And what we would recommend is at the end of the, what we would recommend is for advocates to continue to lobby policymakers to identify allies that would be keen to ensure that, you know, going forward on the agenda, either at the regional or the global level, there's a space to discuss not just long COVID, but, you know, CFS or ME or, you know, all the other communities that we represent here today. So definitely we're on the right track. Let's continue to network, you know, with policymakers, continue to build allies that we can work with and seek opportunities to engage, you know, at the global platforms, you know, for an opportunity to, you know, to put ME and CFS on the topics going forward. Thank you.
Thank you very much. And we may come back to some of this in the discussion later as well. We are going to move on to the final presentation in this section around sort of long COVID and ME/CFS. And I'm going to zoom out a little bit and look at things from the broader neurology angle. And I'm pleased to invite Associate Professor Raymond Helbach from the European Academy of Neurology to address today's meeting and to tell us a little bit about what EAN is doing in this space, and again, how perhaps maybe some of the specific neurological disorders could benefit from that work. And as you're presenting, Raymond, just to say to previous presenters, if you see any questions or comments for you in the Q&A, feel free to send some written replies so we can save a little bit of time as we move through the agenda. But for now, Raymond, the floor is yours.
Thank you very much, Donna. I'm very privileged to talk about the initiatives of the European Academy of Neurology. First, I would like to introduce myself. I'm a neurologist and neurocritical care consultant at the Medical University of Innsbruck in Austria, and I'm also leading the neurocritical care panel of the EAN, European Academy of Neurology. And as many of you may know, that the EAN established a network, the task force COVID-19, very early during the outbreak of the pandemic. And the idea was to help neurologists in the challenges in this global crisis and to get more insights in the impact of neurological manifestations and long-term outcome in COVID-19. And the idea was to make that very open for the members of the EAN, but also for those who are interested in joining these initiatives. These are the members. So the chair is Claudia Bassetti, which is the current president of the EAN. You see the coordinating group, and then 19 members of the panels of the European Academy of Neurology, including Professor Macciarolo Antonella, who is also representing here as panelist. There are several activities now within this year among surveys and publication, and also a survey in combination or in collaboration with EFNA about patient care during COVID-19, a close cooperation with the WHO, especially when it comes to definition of variables and long COVID syndromes. And there were several activities on the EAN pages, which are on the educational side, and also bringing breaking news to the public, and the initiative of the energy registry, which I'm going to discuss in detail in the next slides. So why did we start this registry? And we recently published this statement in the Annals of Neurology. saying that it is important to harmonize data sets. And what we recognized during the pandemic, that lots of publications came out, and it was very difficult to get an idea about how broad the problem of neurological manifestations is. And as you can see here, there are several symptoms and signs and also syndromes, diagnosis, which range from a very low number to a very high number reported in several studies. And this totally depends on whether scientists looked at the hospitalized patient population or outpatient patient population, whether there was an inpatient interview or even only a telephone interview. So we got a broad range of these neurological manifestations reported. And I also fear that we're going to have the same maybe not representative prevalence rates when we talk about long COVID syndromes if we assess patients by telephone interview and not by in-person visits. So that's actually the idea why we came up with the Energy Registry, which is a prospective and also retrospective registry on neurological manifestations. And as you can imagine, the start was in the outbreak of the pandemic. So the idea was to focus on the acute symptoms and signs and also diseases, neurological complications. And for those who are interested, the CRF is published in the European Journal of Neurology. So we included patients which are 18 years or older. This is mostly due to ethical reasons in several countries, because the protocol has to be approved by a local ethical committee. And what makes this registry different from others, that we say that the entry criteria is that the neurology has to evaluate the patient, and this is not what other registries actually do. So the idea was to reach out to as many members, neurologists of the European Academy of Neurology, and you might know the outreach is very broad, more than 2,500 members and more than 47 national societies are affiliated with the European Academy of Neurology. And we tried to achieve consecutive patients for getting an idea about the denominator. We did not ask so far for additional investigations as protocolized investigations, but if investigations have been done, we record them, but this is going to change now in the long-term outcome. And as I said, the prospective and the retrospective data cohort. Another benefit of such a registry is the proper definitions of all symptom signs and also neurological diseases. And what is important for this group is that we also aim for a 6-month and a 12-month outcome, which is for now on a global perspective, obviously by telephone. Very early, we also reached out to other societies, and as I'm part of the GCS NeuroCovid initiative of the Neurocritical Care Society in the United States, we signed a memorandum of understanding between these societies, and with this memorandum of understanding, we actually reach out to more than 400 sites worldwide, which potentially contribute or have contributed to this initiative of COVID-19 acute neurological manifestations, and in the future projects also on long-term neurological manifestations. And this is also just gives you an overview about different societies involved and also countries so far. So European countries, but also countries outside of Europe, which we reach out in the registry. There were several difficulties in terms of ethical committee, getting ethical approval at the beginning, but it's now running quite well, and we have included more than 1,400 patients, have more than 30 active centers in 23 countries across Europe, but as I told you, even in Asia, Africa, and South America. And this is a more global perspective of the sites who showed interest, so quite a lot of sites, and the ones who have ethical approvals are a part of that. But this just shows the network we created, which is important for future studies, especially also when it comes to long COVID syndromes. So in the initial idea when we created this registry. The primary goal was to assess the prevalence of neurological manifestations in the acute COVID-19 disease, to characterize, to phenotype patients, and then to associate these maybe different phenotypes to outcomes. And what you can see here is that one of the secondary endpoint is these neurological complications and the effect on long-term outcome at 6 months or 12 months. So what do we expect, or what did we expect, short-term and long-term findings? I think the positive finding of, or the positive structure what we have is the interaction with other surveillance systems, with other societies. We try to get a more complete picture also in long-term, so that we may be able to get a European or more global view on the impact of the disease. And obviously this infrastructure can be used for focus studies or for prevalence studies for several neurologic manifestations. And there have been several publications now out, and the most recent publication is a collaborative publication in German Network Open with GCS NeuroCovid, the American initiative, and our initiative. And as we have included more than 1,400, the Americans now have included more than 12,000 patients in the registry, and we're working on further publications. And the first publication is about short and long-term outcome is just submitted to BRAIN a few weeks ago, which shows the first results of the energy data. So with our projects and other collaborations, we also collaborate with the NIH by submitting for a grant. We haven't heard back of the grant, but also in this grant, we are looking for post-acute sequelae of SARS-CoV-2 infection. We contribute as much as possible to the WHO initiative in terms of definition of variables. Ettore Beghi is one of the key person in this initiative, and obviously as initially discussed and very nicely outlined in the Horizon Europe, which will come out with the call. And in terms of specific projects we're thinking about, there's several ones which we now think that we want to invest in future, but one of this important project is the post-COVID syndrome and the long COVID syndrome. And having said that, thanks for your attention, and I obviously have to thank my close colleagues in the European Academy of Neurology who created the Energy Network with me, and to Antonella Macciarolo, who is part of the EN COVID-19 task force as well. Thank you very much.
Thank you very much, Ramon, for that broader perspective. And in your final slides, you mentioned the NIH, and that is exactly where we are going now with our next presentation. And it's my pleasure to invite Dr. Vicky Whitmore to this virtual meeting today. And Vicky, great if we could hear from you maybe what the NIH is doing in this sphere of the link between COVID-19 and post-viral syndromes like ME, but also in the area of ME more broadly, and what perhaps we here in Europe could learn from you guys. So Vicky, over to you.
Great. Are you seeing my slides?
Perfectly.
Okay, thank you. Well, thanks very much for the invitation to be with you here today. It's been a very interesting meeting so far. I'm learning a lot about what's happening in Europe. To introduce myself, I'm Vicky Whitmore. I'm a program director in the National Institute of Neurological Disorders and Stroke at the National Institutes of Health. And in that capacity, I oversee grants on ME/CFS as well as epilepsy. But more broadly, I work very closely with the director of NINDS, Dr. Koroshetz, to coordinate our trans NIH working group, which involves individuals like myself from 23 of the institutes, offices, and centers across NIH, where we work to coordinate research on ME/CFS, and also work with Dr. Koroshetz and individuals from the CDC, the Center for Disease Control and Prevention, to coordinate an interagency working group where we're trying to bring together individuals and representatives from the federal agencies to also coordinate our activities focused primarily on ME/CFS. So I'm not advancing, let's see. There we go. So this slide shows you the funding, total funding by NIH for research on ME/CFS, and you can see that up through 2016, it wasn't more than 8 million per year. What happened between 2016 and 2017 is that we funded ME/CFS collaborative research centers, and I'll come back to that. But I have to say that the majority of NIH funding is investigator initiated, meaning that people, researchers, investigators submit grants to NIH on the topics that they choose to study that are reviewed and funded that are really outside of any specific calls for grant applications. So in 2015, NINDS took over coordinating the Trans NIH ME/CFS working group. And at that time, we really did a close look and tried to examine what were the challenges for doing research on ME/CFS. And we found that there were a very small number of ME/CFS investigators in the United States. Most of the healthcare providers were and still are actually in private practice and not associated with academic institutions, which makes research in clinical research and research in ME/CFS somewhat challenging. There were a small number of trainees in the pipeline. Very few grants were being submitted to NIH for review. Research studies that were funded were enrolling very small numbers of study participants. There's very heterogeneous nature of ME/CFS, both in terms of the onset of disease, the symptoms that are seen, as well as the age range that can be anywhere from children to the elderly. There was a lack of data sharing and, oops, sorry, let me go back. I'm having a hard time seeing the bottom of my screen, so I can't remember what I wrote there. Sorry about that. But I'll just go on anyway. So I'm the type of person that likes a challenge. And so we took this on and spent quite a bit of time trying to discuss how can we really make an impact on research on ME/CFS in the United States. And we realized we needed to expand the number of investigators, increase the number of trainees, gain interest from investigators in related fields, expand the scope of research, support rigorous research, and develop tools for data sharing. We did not have a biorepository that had any biospecimens from individuals with ME/CFS, and we really needed to foster collaboration. So in 2016, we released funding announcements for multidisciplinary centers and a data management coordinating center, while still encouraging grants to come in from investigators through the investigator-initiated grant application pool. And we funded 3 collaborative research centers and a coordinating center in 2017 for 5 years. The total funding support over the 5 years will be about $35 million investment into ME/CFS research. So all 3 of the centers are focused on studying the pathophysiology of ME using various omic approaches. And what we've learned and what happened from funding these centers is that each center brought several new investigators to the field. And in fact, there are about 37 new investigators who had never done research on ME/CFS who are collaborating with one or more of the centers. 2 of the centers have graduate students and postdoctoral fellows actively involved in the research. 2 of the centers had to recruit all of the study participants from the get-go since we had no biorepository. And I have to say, all of the research, as I'm sure happened globally, was significantly impacted by the pandemic, where labs and clinical studies were completely shut down for months at a time. So data sharing was initially an issue, but our data coordinating center has developed a tool called MAP ME/CFS, where data can be shared either publicly or between collaborators. Before it's published, can be shared privately. We now have a biorepository of ME/CFS biospecimens that are available for researchers that can be queried, and requests can be made through a second tool called Search ME/CFS. The investigators meet monthly to foster cooperation and collaboration between the centers. And we've now added the Canadian funded I Can See a Knee ME/CFS network, research network into our network, and they meet with us during these monthly calls. And we're actually also, our data coordinating center is helping them with some of their database needs. We added a community advisory committee that is run by Alison Canis at Columbia, which is one of the 3 centers, to really bring in that patient perspective to provide feedback and input. And so the end result of this, I think, is that it has greatly accelerated rigorous research in the United States. And the centers, we will be recompeting the funding for the centers and the data coordinating center in 2022. And now we have long COVID. So initially, NIH called long COVID PASC, or post-acute sequelae of SARS-CoV-2, but that name really did not catch in the community. So I think most of us call it long COVID. And thanks to the advocacy of the patient organizations, the US Congress provided $1.15 billion over 4 years to NIH for research on long COVID. So NIH released research opportunity announcements, and we received over 300 applications from these funding announcements. And they're using what's called an other transactional authority, which is an interesting mechanism that NIH has, where the funding the grant applications came in, they were reviewed, and they're selecting parts of the applications to piece together the network that will be funded through this, utilizing these funds. So funding will be provided to clinical sites for the recruitment and testing of individuals who are acute and post-COVID, as well as collecting biospecimens. And there are cores that are going to be supported as well for infrastructure, a clinical science core, a data science core, and the third core. So this initiative is now called Recover. And so a recovery cohort will be recruited. So this will be everything from adults to children to pregnant women, and there'll also be autopsy studies, understanding that people do not necessarily die from long COVID, but die with long COVID, which will give us the opportunity to do autopsy studies. There will soon be a kickoff meeting that will bring all investigators together. My understanding is that the contracts and negotiations are still underway with the sites, so they have not yet been announced, but will be soon. And all of the investigators will agree on a common protocol, common data elements that will be deployed across all of the sites for these studies. And so the goal here is to compare and look at those individuals who develop long COVID after the acute infection compared to those who recover. I've been part of the working group that's thought about the protocol and putting a draft protocol in place that the investigators will start with in their discussions. And we've been very mindful of making sure that there are tests and instruments and studies that will be included in the protocol that will identify individuals with long COVID who meet criteria to be diagnosed with ME/CFS. And all of the study participants will be followed for up to 2 years in this study. So we'll be able to study the evolution from the acute infectious phase through to the chronic symptoms of long COVID, with biospecimens and clinical data being collected along the way for all of these individuals. So lessons learned here is that, as you all, I'm sure, experienced, the early part of the pandemic was a crisis period, and all of the NIH focus was on development of the vaccines and treatments for COVID. And even back a year ago, the patients with ME/CFS, and the patient advocates and long haulers were telling us to pay attention, that this was coming, that long COVID was going to be a reality. But as I said, the entire focus was on vaccines and diagnostics and treatment of COVID. So it would have been nice had we been able to recruit back a year ago when the pandemic was raging, but we didn't. But here in the United States, I looked at the Johns Hopkins map, which is keeping track nationwide of new cases and deaths from COVID. And there are still 15,000 new cases of SARS-CoV-2 being diagnosed every day in the United States. So we feel pretty confident that the sites will be able to recruit 10 to 20,000 individuals for the study across the United States. So I think the other concern, having been on the review side of the applications, is that the application was rushed. We wanted to get things out the door. And so critical information was not necessarily collected in the applications, which made reviewing the applications quite challenging. But I think that there's been some follow-up information gathered. And I think that the funding plan that's going forward to study long COVID is pretty solid, and hopefully will provide some really critical information for us. So I think the other thing, and this was raised by someone also, is that there's been confusing messaging by some of the patient advocates that long COVID is the same as ME/CFS, while others want to keep them separate. And I think our position is that studying long COVID provides a unique opportunity to study the development of the symptoms of long COVID, and in some individuals who will be diagnosed with ME/CFS in both children and adults, something that we've not ever had the opportunity to do following an acute infection. So with that, I will stop and thank you for your attention.
Thank you very much, Dr. Whittemore. I think you've really sort of shown us some exciting developments that are happening in the research space, not only in the area of long COVID and ME/CFS, but actually in ME/CFS as a standalone area of research. And I think from what we've heard over the course of today, we have a long way to come in Europe to catch up with some of what is happening in the US, but there has been progress. And our next speaker, who is Dr. Sabine de Jong from the Netherlands, is going to tell us about what's happening at a national level in terms of research into this sector, and maybe what lessons other countries across Europe could learn. So Sabine, the floor is yours.
Thank you, Dana. Thank you for having me today. Yes, like you said, as a program manager at Zonneweg in the Netherlands, I will talk about the trajectory in which in the Netherlands. So Zonneweg in the Netherlands is the governmental body that funds healthcare research, and at Zonneweg we stimulate health research throughout the entire knowledge chain, so from fundamental research to implementation. We promote and fund the development and also the application of knowledge in areas of prevention, care and health. And throughout all these programs, there's a strong focus on patient participation. And then a bit about ME/CFS in the Netherlands. There's some 30 to 40 ME/CFS patients in the Netherlands, according at least to one estimate, on a population of 17 million people. Medical practice for ME/CFS patients is problematic. There's a lack of diagnostic tools and effective therapeutic options, as there is in other countries, of course. And also the medical need of ME/CFS patients is underappreciated. Patients do not always feel taken seriously by medical practitioners in clinical practice, as well as in occupational health practices. And there are no good clinical pathways, so there's not a good referral system between GPs, medical specialists in hospitals, and other medical professionals. What's linked with that is that there is no good biomedical research infrastructure. So what happened in the Netherlands is that in 2013, petition was started by concerned citizens, patients. It was called Erken ME, so that's Dutch for Acknowledge ME. And this petition was signed by 56,000 citizens. And the petition stated that ME is not adequately diagnosed and treated in the Netherlands, and that there should be more biomedical research on ME/CFS. Now, following this petition, the Ministry of Health, Welfare and Sports commissioned the Dutch Health Council to write a report on ME/CFS. And ultimately in 2018, a report came out, and in it the Dutch Health Council stated that, clearly stated that ME/CFS is a serious disease, and it advised the government to set up a research program for ME/CFS. And of course, this is where we came in as ZonMW, and we were commissioned by the Ministry of Health to firstly set up or write a research agenda on ME/CFS in order to identify knowledge gaps, but also in order to gather support for a future research program on ME/CFS among stakeholders, like, of course, patients and researchers, but also clinical practitioners, policymakers, guideline developers, etc. And we finished this research agenda at the end of 2020, so just last year. And the research agenda has a strong focus, of course, on biomedical research. So how did we assemble this research agenda? As I said, ZonMW highlights patient participation, nothing about us without us. Maybe you know the phrase. Yeah, it's taken seriously at ZonMW, and well, there are 5 ME/CFS patient organizations in the Netherlands, so that's a bit of a, well, there's a bit of division, but of these 4 wanted to collaborate with us on writing the research agenda. And this was a close collaboration with frequent contact between ZonMW and the patient and patient representatives. We also contracted a patient liaison, which we called him, and that was a person who helped these patient organizations in the process of the research agenda. So to help formulate their voices, to reshape divided voices into one strong voice that cannot be overlooked, neither in this process nor in the future in the research program. At least that was one objective. And the research agenda was written by a steering group, and in the steering group, 4 members of the patient organizations working with us were represented. They were members of the steering group. And of course, at all events organized within the research agenda trajectory, patients and patient representatives were present. So what we did in order to develop this research agenda, of course, we looked at the current state of research on ME/CFS abroad. There was the literature study by the Health Council and other literature that we looked into. Steering group members visited conferences, and what we did, we did a survey among researchers abroad, asking them what lines of research are most promising in ME/CFS and how a research program should be set up practically, what these researchers thought pitfalls in ME/CFS research are, and how patients can be involved in ME/CFS research. And there was a good response on the survey. For those present today, thank you for filling out the questionnaire. And this survey formed sort of the backbone of the research agenda that we wrote. We also organized 4 academic workshops in order to engage Dutch scientists in ME/CFS research, in order to prepare the research infrastructure for the program to come. And we had what we call the program day, at which all sorts of stakeholders could give their say on what they thought the research programs should address. And in doing so, we developed 4 basic lines of research: a fundamental epidemiological, clinical, research line, and also we stated the objective to improve the clinical practice. But because of the time, I can't go into all these research lines in depth, but most of you will be familiar with the main lines of research in ME/CFS, I think. So just to state quickly, with regard to fundamental research, the research agenda suggested doing research on the immune system, on brain and neurological dysfunctions and dysfunctions at cellular level, the energy metabolism. With regard to epidemiological research, the research agenda suggested looking into the various putative causes of ME/CFS, genetic, environmental, infectious, looking into the development of ME/CFS throughout time, and whether you can make predictions about who will develop ME/CFS, and also to focus on describing ME/CFS, for instance, by identifying subgroups that can have a specific pathophysiology. With regard to clinical research, there's room for research on the diagnosis, therapies, and symptom treatments. So, for instance, studies in analogy with the microbiota transplant study that Professor Bergquist mentioned earlier today. So those were the biomedically oriented lines of research suggested in the research agenda. But our research agenda also proposes implementing biomedical knowledge among medical practitioners, health professionals, medical examiners, medical guideline developers, and to grant projects that improve the general discourse on ME/CFS in the Netherlands. So this is what a research agenda basically sums up our research agenda. But where do we stand now? Currently, or some time ago, our Dutch Minister of Health announced to finance the research program on ME/CFS, so that's good news. And of course, it should be based on the research agenda. It will be a 28.5 million euro research program for a period of 10 years. The main focus of the program will be on biomedical research and to set up the research infrastructure for ME/CFS. And that will be built around Dutch ME/CFS patient cohort. So the aim is to have all studies work on the same cohort to stimulate exchange of data and ideas and theories on ME/CFS. The research in the program should be transdisciplinary, and it should build on research on ME/CFS that's conducted abroad. And of course, it's important in the program for patients to have a say in the research that is conducted at multiple levels. So on the level of the actual research, but also in the evaluation process of the research proposals, in which patients will be a member of the program committee. So what are the next steps? Well, the program is under development currently. We're establishing ways for patients to participate in our working processes. I'm always there. We're setting up the program committee. We're establishing criteria for awarding grants. For instance, at Zonamway, all applying institutes should be Dutch, but we also want to stimulate international research collaborations. So we're currently inventorying the possibilities for doing so. And we're busy creating ways of harmonizing the data that will arise from different subcohorts that might apply. So where we stand now is that we expect our first call of proposals will be by the end of 2021, depending on the progress of public policy. But my last and most enthusiastic note is that we're quite excited by what we hear in the field, because our contact with researchers gives the impression that several large research consortia are currently forming. And that would mean, of course, that the intent of the research agenda is achieved, and that it's been a successful process. So I'll stop at that. Thank you.
Thank you very much, Sabine, and it's great to see a country in Europe taking up the mantle and really pushing forward with this type of funding for research. Now, I'm going to move on, and I'm sorry, Jens, I'm going to skip you again, and I'm going to come back to you. And this is because our next speaker, Jan Shadrach, who is the Global TA Head of Neuroscience and Rare Diseases at Roche, has just joined us. Jan, I realize you've been sitting there waiting for your turn, and you've only got 5 minutes at this point, but we really appreciate you making time in your schedule to join us today. And I think based on some of the earlier discussions, it would be great to hear how we can get beyond that sort of basic and fundamental research in an area like ME and really start to push clinical research that could bring treatments to the patients who so desperately need them. And we'd be eager to hear your thoughts on how we can take these neglected diseases and get them onto a commercial agenda and really transform the lives of those patients. So over to you. I realize time is short, but glad you can be with us.
Thank you, Donna, and hello, everybody. It's a great pleasure to join this meeting, and I'm really impressed about this activity and how you have brought together the variety of stakeholders in this very important area of disease and unmet medical needs. And also I learned that this is intended to be a series, and I really look forward to its continuation, where we can also deepen a little bit the perspective from the industry. So I joined to provide a few thoughts from a industry representative perspective. A few words to myself. I am a trained physician. I focused on psychiatry and neuropharmacology. I joined the industry about 20 years ago and always worked in clinical research and then bringing the outcomes of this, so new medical solutions into the reality of medical practice, what we call medical affairs. And I currently serve at Hoffmann La Roche, a Swiss biopharmaceutical company, as the head for neuroscience and rare diseases, where we're at the frontier of many areas of large unmet medical needs and evolving science. From the last 20 minutes or so that I was able to join, I'm truly impressed of how much is already on a good track and trajectory to eventually find its way to something that might be suitable also where the industry can be true partners in driving this forward. And I thought to give you a few very high level perspectives that at least from our approach here as a frontier developer and major investor in research and development, we consider and are important. And I think there's very large unmet medical need on a patient and family perspective, and also the societal burden. So these are usually two of the key dimensions we look at, is unmet medical needs, but also not only on the individual level, but how much does it really impact, if you want, the health and well-being of communities and societies? Because our mission is to continue to create transformative medicines, but also to see how we can introduce them, being aware that we also need to consider the impact of cost burden and how we can positively address the cost burden that the diseases impose, but that the medical solutions we may develop also address the reality of health economics. So these are two of the key elements. The biggest challenge I see with these diseases like ME, CFS is a little bit of a reminiscent of other disease areas that, in the past struggled with the same. I'm thinking of restless leg syndrome, many of the rare diseases that are also currently emerging and had to go through this journey. It reminds me of chronic pain, where I in my years in academia worked a lot of fibromyalgia. So I think there's a lot of common themes, but all the elements you're currently doing will all serve towards the goal to maybe then finally also get the traction for a good partnership between industry and academia and patient organizations and policymakers. The biggest challenge, and as you probably know, is the neurobiology. And that's a little bit where I see where it's hard to find an entry point, because in addition to clarify the patient need, the societal needs, we need a strong scientific rationale to be able to tackle it meaningfully with biopharmacological means. And this is certainly one of those diseases where the etiopathopathology, the pathomechanisms are still a little bit elusive. Doesn't mean they're not existent, they're just very difficult to untangle and to identify. So I think the more we can enable this, and the more also academic research and data collection and registries and many of the efforts that were shared with us foster those, the more the chances will rise that we will learn more, and also from maybe common mechanisms with long COVID, which I fully agree shares a lot of the same phenotype. So what did we learn from other disease areas, and maybe a few high-level recommendations? I think we have many of the elements in place that should further enable and grow this. And I really like that you also, as let's say a European alliance, also include key perspectives from the US. What has been instrumental for many of the rare disease areas were patient-driven, independent, strong foundations. And I'm thinking of neuromyelitis optica, for instance, or in the area of spinal muscular atrophy, where there's the SMA Foundation that really was a major voice, not only enabling the collection of funds, because biomedical research is incredibly risky and costly, but also develop a strong unified voice, not only in the US, but then also globally. So I don't know to which extent there's already a strong global unified foundation that can serve your mission and your ambitions. And that's something what could learn from other disease areas. In Europe, I'm aware of AFM Teleton, who does the very same for neuromuscular diseases and are very influential. So that's certainly something I'd love to continue the dialogue and the perspective to see what can learn from others and how it enables the continuation of driving this forward. And just maybe one last aspect, this has been to the extent and the entrepreneurship of many of the US driven foundations is that before they wait for big pharma, is that they created their own biotechnology companies driving biomedical research and solutions that have the same quality than the established biopharmaceutical companies and have become a competitor to the established companies. So there is basically unlimited possibilities to really spark and catalyze the research and the next step forward. And I think as Europeans, this is something we can really learn from our colleagues, especially in North America and particularly in the US. So let me stop here. I know time flies and we're pressed on time, but I really look forward to continue the dialogue with you. And I'm super excited that you brought all of these together and how you approach this as a joint collaborative effort. Over to you, Donna.
Thank you very much, Jan. So for the last 10 minutes, we've got one presentation left, and I'm sorry, Jens, I've kept pushing you further and further down the agenda, but now the time has come. And it's my pleasure to hand over to you, Docent Jens Boman, who is going to give us a perspective from Sweden, a more clinical perspective in terms of how we can set up a hospital-based service for ME/CFS.
Thank you very much. I try to share my slides.
Yeah, we can see them perfectly.
You see them? Okay. So we are late, so I will quickly try to answer two questions. So why are we doing this and how? So the topic is starting an advanced ME/CSF clinical university hospital-based service. And I'm based in Umeå at the University Hospital in northern Sweden, covering half of Sweden's geographic area, but less than 10% of the population. As you know, this is a very serious, complex condition. The cause is unknown, and it's been classified as a disease of the central nervous system by WHO since 1969. And we have seen today there are many people affected in Europe and globally, and this is a conservative estimate based on the Canadian consensus criteria. A lot of symptoms, complicated symptoms affecting sleep, immune system, fatigue, PEM, etc. And if you look at the quality of life, we have healthy controls to the left, and to the right, ME/CSF. And between other severe conditions like rheumatoid arthritis, depression, cardiac failure. So it's very important to help these patients. So the challenge for me was to plan for an advanced clinical university hospital-based service. So the strategies was to update on research, what the opportunities were for patients in Sweden last year, and discussions and dialogue with the politicians and policymakers, and dialogue with ME/CSF Patient Association, and very great collaboration. And yesterday we had our 11th meeting out of in total 75. And of course, dialogue with manager, clinicians in the region. How should we, where to put this clinic, placing, management, which specialities, etc. So I had to do a plan and a budget for this. And why put it at a university hospital? Yeah, because there's a need for a multidisciplinary approach with several specialities, and also need for multi-professional approach, and we need to perform both research and education about this disease. So in short, the plan is 3 steps. First, the basic clinical investigation at the health centers by the general practitioners. Then referral to this clinic at the university hospital for a diagnosis. And finally, an individual tailor-made plan for treatment, patient management, and follow-up. And the decision was, the politicians decided on this on March the 3rd, and we are planning to start after the summer, probably in October, and then start planning for research and education. So that was very brief. Why and how?
Thank you very much, and thank you particularly for keeping it brief as we are running out of time. But I think we captured a lot of information, and as we said, we can send the slides to everybody after the presentations today.
Yeah, that's my plan. Thank you.
Thank you so much. So at this point, don't worry, I'm not going to invite all of the people from all of these organizations to join in the final plenary session. I think we've taken questions and discussion as we move through the meeting in a way. So I think at this point, looking at the Q&A, a lot of the questions have already been answered, and the panelists will continue to answer questions for the next few minutes there.